Good evening, salam to all of you. So we are in the 36th webinar of Conceptual Basis of Urology course. And we're going to have a little discussion on the current imaging in the initial evaluation of both kidney and bladder cancer. There have been some controversies, there have been some recent developments. And most of these things have been discussed in the last ASCO GU and also in the just concluded European Association of Urology meeting. And I thought that it's a wonderful opportunity that we keep our audience of the Conceptual Basis of Urology course abreast with these developments. I'm fortunate today to have Mr. Zishan Aslam, whose affiliation has changed. It's not the same that is written there. His sympathies stays the same, but his affiliation, institutional affiliation, keep changing. So currently he is in Aberdeen, the famous place in Aberdeen. And Mr. Mazhar Sheikh, as you all know, works in Blackpool Hospital. Zishan has a special interest in kidney cancer, and he's part of a trial about which we're going to talk a little bit in this presentation as well. Mazhar has an area of interest in bladder cancer. So we'll have the good opportunity of discussing both of these cancers in presence of our two distinguished colleagues. Please feel free to ask questions, write in the chat box. And if you have something that you would like to ask, just raise your hand and we will allow you to speak. So I'm going to give a little background. The whole idea is that we can have a little interactive discussion. So we're going to talk about the kidney cancer first, and then we will take the bladder cancer. My name is Hammad Ather. I'm Professor of Urology at Aga Khan University in Karachi. Now, this is a very interesting data, something that we all have seen over the years, is that we are identifying wherever we live, in the first world or in the developing world, what we are seeing is that we are identifying more and more kidney cancers. However, what has remained static is the mortality rate, which is strange. And we're going to look at some of the factors which are responsible for this static mortality rate. So between 1975 and 2014, we are identifying more than double the number of cases that we were identifying in 1975. However, the mortality rate has remained relatively stable. And this is coming from the Seer Kidney Cancer Database, so obviously North American data. So what it essentially means, it means that we are detecting more cancer or more masses, which means that there will be higher rate of surgery, so we are intervening more. However, it has not impacted mortality. This is the data which was recently shared in the EAU meeting, and this is coming from Holland. And as you can see, that the highest increase is in the number of stage 1 or smaller cancers. So we're basically talking about T1A cancers, which has seen a significant increase from just over 400 cancers in 1999, just at the turn of the century, to over 1,000. So it's 2 and 2.5 times increase in the number of small kidney cancers that we are identifying. There've been rise in the number of stage 4 cancers as well. So we're detecting more metastatic disease. So both of these two extremes in kidney cancer poses special challenge. We are, however, going to mostly dwell on the low-grade cancer. So as we know that in urology, the cornerstone of diagnosis is imaging. And the conventional imaging that is being used in the identification and diagnosis of kidney cancers is ultrasound, CT, and MRI. MRI has made a more recent breakthrough in kidney cancer as well as it has in prostate and bladder cancer. What is the idea of imaging, or the goals of imaging, is that we should be able to diagnose a cancer compared to any other renal mass like a cyst. We are able to characterize the tumor, which means that we are able to identify whether this renal mass is benign or malignant. And if it is malignant, probably what kind of malignancy. We know that vast majority is clear cell carcinomas. However, there are other variants, other varieties, histological varieties as well, with variable potential for progression. And obviously, as for any other cancer, we need to be able to stage the disease. So we should know whether a T1 is actually a T1 cancer or it is a T3A cancer, for example. Like if you have a small kidney cancer, which according to the T staging is characterized as a T1A or T1B cancer, if it is involving the renal hilar fat or perinephric fat, it really becomes T3A irrespective of the size. And identification of this is extremely important because the decision about treatment, i.e. partial or radical nephrectomy, can be made preoperatively. Now, if you look at the EAU guideline, one important thing is the first line, which says that perform a renal tumor biopsy before ablative therapy and systemic therapy without previous pathology. So, or in the context of small renal cancers, if the decision is to ablate them, we need to have a biopsy, because without biopsy, you would not be able to make a right decision about follow-up. Once you have ablated them without biopsy, you probably would not know whether it was a cancer in the first place or not, and how aggressively you need to follow them up. Now, I remember my days in training, and it is just before the turn of the century, that small renal cancers, like 1 to 2 centimeter tumors, were generally considered as adenomas or benign tumors. We didn't have that sophisticated classification system that we have now. So life was quite simple. We would not jump into treating those patients because partial nephrectomy was not that commonly performed. And most of these tumors or masses were essentially followed by imaging, which used to be ultrasound, at most CT scan. However, if you look at the most recent WHO 2022 classification, there is a broad range of benign tumors. And these tumors, some of which are relatively common, and we are introduced to these tumors. Some of them have been recently classified. So renal papillary adenoma, oncocytoma, we all know. However, there's another entity which is called clear cell papillary renal tumor. Now, neither it's a clear cell carcinoma nor it's a papillary cancer. It is a clear cell papillary renal tumor, and it's a benign tumor. The metanephric adenoma, mixed epithelial and stromal tumors, angiomyolipoma, or picomas, they're all benign tumors, and they are seen in about 20% of our partial nephrectomy. So we need to be very careful about identification of these tumors. Does our current imaging allow us to identify these preoperatively or without biopsy is a question that we need to address today. So angiomyolipomas have very classical picture on ultrasound and CT scan and MRI. However, And this classical picture is because of the presence of fat in angiomyolipomas. But there are fat deficient angiomyolipomas, and which makes life difficult because it would be difficult to identify whether this T1 mass in the bladder in the kidney is an angiomyolipoma with just fat deficient, or it is it's a renal cell carcinoma and likely to be a clear cell renal cell carcinoma. So biopsy is probably important. So angiomyolipomas with no fat are Paxate negative. Similarly, oncocytomas, again, not very easy to identify on our current imaging. And what is happening in terms of the advances in imaging is something that we're going to talk about in this presentation. So clear cell, the oncocytomas need to be identified and differentiated from chromophore cancers. And even with pathology, if the pathologist is not really trained, he or she can miss out between these two entities. Definitely, they are difficult to be differentiated on imaging. Clear cell papillary tumor, again, as I've said, it is a benign tumor. It's not a clear cell carcinoma, or it's not a papillary cancer. It's a benign cancer, which is CK7 and carbonic anhydrase 9 positive. So these are some of the entities which create diagnostic problems, and we need to be clear in how we can identify these. So diagnosis of kidney masses, we need to make two major decisions about. Number one, is it the solid mass is benign or malignant? CT scan has a sensitivity of 88%, but low specificity. So this is an issue with the significantly low negative predictive value. MR, on the other hand, is slightly more sensitive, as well as quite specific. So MR is taking an advantage, although we know that kidney cancer, our first-line imaging, is CT scan. However, it is important to understand that MR is making a significant impact in our ability to differentiate benign from malignant cancers. Then we have another entity, which is the cystic masses. And again, cystic masses, MR is better than CT. But there's another entity, which is called the contrast-enhanced ultrasound. And for those of you who are interested in this imaging modality, they can refer to our conceptual basis of urology course of November 2022, which is available on our Karachi Urology, PAUS Karachi website. You can go and log on and listen to this 1-hour talk on the contrast-enhanced ultrasound and its ability to differentiate between various types of renal masses. So this contrast-enhanced ultrasound is a real-time imaging, and it is significantly superior in demonstrating the septa. And as you remember the Bosnia classification, the real difference between benign and malignant thing is the thickness of the septa, the wall of the cystic mass, the fine enhancement that you see in the septa and within the cystic areas. So essentially, its sensitivity is not very high, but it is a very high specificity. So, and with negative predictive value of 100%. So ultrasound, contrast-enhanced ultrasound, really provides another very important modality for imaging, particularly in complex cystic masses, which are otherwise difficult to differentiate. So contrast and ultrasound differentiate between solid and cystic lesions. It has high sensitivity to detect minimal blood flow, something that can be missed out in both nephrographic and corticomedullary phases, because the variation in the nephrographic and corticomedullary phases flow really determine whether the tumor is benign and malignant, and what is the difference between the normal renal parenchyma and its enhancement versus that of the tumor. Another important thing is that it will be able to differentiate tumors from cysts containing blood and debris. So on a CT scan, it would be really difficult sometimes to differentiate between the two. However, the real-time nature of contrast-enhanced ultrasound is able to differentiate between cystic masses, which contains blood and debris rather than solid component. The solid hypovascular tumors enhance on contrast ultrasound. So tumors which on a CT scan are hypovascular, are not enhancing that much because they're hypovascular tumors, they would enhance invariably on the contrast enhanced ultrasound. Lesions which are non-enhancing or which are not enhancing on ultrasound can be safely characterized as benign cysts. So this is something which shows higher negative predictive value. In patients who have end-stage renal disease, and we know that there is a rising incidence of end-stage renal disease all over the world, in these patients, it is difficult to do either of the two imaging safely, i.e. the CT with contrast or MR scans. And in this situation, the contrast-enhanced ultrasound is really very helpful. And these are some of the examples of patient with end-stage renal disease. Contrast cannot be given. And in this situation, this little hump was identified to be a tumor on contrast ultrasound. This is a CT of a 50-year-old man, and you can see that a non-contrast CT essentially shows a little area which is suspicious at the lower pole of the right kidney. The post-contrast corticomedullary images with fat suppression T1 weighted MR basically show a 1 centimeter lower pole cortical lesion without definitive enhancement. And the enhancement was recorded to be less than 13%. However, when the same patient had an ultrasound, a contrast-enhanced ultrasound, there is a definite solid nodule, as you can see, the arrow pointing. This was enhancing more than the, less than the cortex, and as a consequence, identified to be likely to be a cancer. The patient underwent pathological evaluation, and it showed a clear cell carcinoma. So if we look at these two non-contrast and contrast-enhanced images, we probably would not be able to make a definite diagnosis. However, the ultrasound does. So characterization of complex cystic renal masses, ultrasound, contrast-enhanced ultrasound is superior to CT in detecting minimal enhancement of septa, cystic wall, and to show solid components. It can also provide modality for follow-up of non-surgical lesions, lesions which have not been operated upon, because it can detect slight changes in the thickness of the wall of the septa, appearance of a solid nodule, and contrast enhanced which is different from the previous scan. Obviously, there are clear benefits that it reduces cost as well as the radiation. So there's obviously no radiation. However, there are certain limitations to the use of ultrasound, and we know that the body habitus of a patient, the presence of bowel gas and drips makes it sometimes difficult, patient's constitution, and more importantly, the expertise, the ability of the operator to be able to identify these subtle changes so the routine typically conveyor belt ultrasound that we have in at least our part of the world, where patient after patient is undergoing ultrasound, is not really the best way. And you need to, particularly for oncological patients, important that you spend some time and be able to identify the subtle changes there in order to make a diagnosis. We all know that not all solid masses in kidney are cancerous. Students in urology, the trainees, remember that there are 3 or 4 important clinical conditions like the prominent column of Burton. As you can see here, I mean, to a casual observer, it seems like a completely endophytic solid renal mass with enhancement pattern similar to that of the renal cortex. So, but this is a prominent column of Burton. The persistent fetal ovulation, as you can see in probably bovine kidneys. So again, this is another condition which is should be differentiated from a mass. Presence of a Rome-Derry hump. Again, another benign variation. So, and also that if there is a previous parenchymal injury or insult, the parenchyma around that insult show element of cortical scarring, which makes identification or differentiation between a small tumor versus difficult. Conventional ultrasound would definitely show that the medullary pyramid is identified within these pseudo-tumors. So this is one of the characteristic feature that you need to remember. And you would see the normal renal vessels if you do a Doppler ultrasound. However, if you do contrast-enhanced ultrasound, you'll be able to identify enhancing characteristics of the surrounding parenchyma in all vascular phases. This is in contrast to neoplasm, where there is variation in the corticomedullary versus nephrographic phase of contrast enhancement between tumor and the normal parenchyma. So the other examples of solid tumors and how the contrast enhanced ultrasound is able to differentiate between a pseudo-tumor versus a tumor. The first image on the left side of the screen is a grayscale ultrasound, which show focal thickening of the pit portion of the renal parenchyma, suggesting an isoechoic renal tumor. However, color Doppler did not show, a color Doppler did not allow further characterization of this mass. The contrast-enhanced ultrasound in the cortical phase reveal enhancements of the cortical portion of the focal thickening, with the medullary portion shows delayed enhancement. Again, this is something which is a very valuable tool. The 2F cyst, the type 3 cyst, and type 4 cyst can all be very clearly identified. As you can see that there is a vegetating solid lesion in these C film here is specified by the asterisk, which is characteristic of a renal tumor, and this was a papillary carcinoma. Again, a lesion which is on a contrast enhanced CT scan was considered as an indeterminate left renal cyst, categorized as Bosniak 3, with the presence of multiple palely enhancing septa. As you can see, that they are very fine septa, hair-like in this. So it was characterized as 3. The contrast ultrasound, however, show enhancement of the wall of the septa, and it was histologically proved to be a multilocular cystic renal cell carcinoma. Okay, so this is as far as the use of conventional imaging is concerned in relation to characterization of these masses, differentiation between benign versus malignant tumors, and various variation or anatomical variation, which can pose diagnostic challenge. One of the very important staging parameter is to identify presence of lymph nodes. Fortunately, they're not very frequent, but presence of lymph node is one of the significant prognostic factor. Lymph node involvement in RCC doubles the chances of distant metastases and significantly reduces the 5-year survival. Use of color Doppler sonography, MR, and the certain types of MR scans like lymphotrophic nanopeptide MR are some of the modalities, along with the multi-detector CT scan and PET scan, the fluoro glucose PET scan. So these are some of the modalities. However, MR has demonstrated a high sensitivity for detection of these lymph nodes. Whereas the FDG PET scan has very high specificity. The MR specificity is low. So it is really currently considered that in situation where there is clinical suspicion of a nodal disease indicated by an MR scan, FDG PET can really complement. But FDG PET itself has very low sensitivity. So it is only after the MR scan is identified or raises suspicion of a lymph node that the FDG PET should be done, and not in the other sequence. So combination of MR and FDG PET may offer very high accuracy in identifying the presence of nodal disease. The major problem that we often face is in the evaluation of small renal masses. There is significant heterogeneity in these small renal masses. The histology is variable. The aggressiveness, benign versus renal tumor, and various types of renal tumor. And whenever we identify a small renal mass, it's important that we assess the presence of fat, which is essentially identification of angiomyolipomas. The enhancement pattern, differentiation of various renal tumor subtypes is also important, because when you put it in relation to the patient's comorbidity status, you probably make a decision of doing an intervention or not doing an intervention, particularly in the elderly patient. So this is one of the algorithms described by Nicolo. And so if you identify a solid nodular lesion and the scan shows, a CT scan, and non-CT scan shows fat, it is likely to be an angiomyolipoma. If there is no fat, then it is considered as an indeterminate lesion and require further evaluation. As I've said earlier, although not very common, but the fat poor angiomyolipomas are there. They're about 5 to 7%. So enhanced CT would be needed in this situation. Does it show enhancement hypervascular? Then the renal parenchyma, you should really be considering oncocytoma or clear cell carcinoma. Or hypovascular tumors, the chromophobe RCC and papillary RCC are possibilities. So if you look at these two cases, the top row is a 63-year-old male with pathology-proven angiomyolipoma. Now, if you look at the non-contrast enhanced CT, and then you look at this contrast enhanced CT, what you're essentially seeing is a differential pattern of enhancement. And this is a fat poor angiomyolipoma. It would be really difficult unless you do an MR or a contrast enhanced CT to identify this as to be an RCC. Similarly, if you look at this lower case, it's about the same gender, same age patient with same morbidity status, non-contrast CT versus contrast CT in corticomedullary and nephrographic phase. And the pattern in which there is a washout is basically an indicative of presence of a malignant tumor in this kidney, and it came out to be a renal cell carcinoma. Dual energy spectral CT. I don't know how frequently it is performed in our part of the world, and I'll seek input from Zishan and also from Mazhar that how frequently it is done there. But it is shown to be an important modality in differentiating RCC from benign tumors. Also for angiomyolipomas, which are fat poor, can be identified. Okay, so I'll stop here, and I would like Mr. Zishan Aslam to say a few things about his personal practice and experience in characterization and use of various imaging modalities, the sequence. And if there are any questions, please feel free to write in the chat box. Zishan.
Yeah, thank you very much, sir. Thanks for updating all our knowledge on the imaging. So in terms of imaging modalities that we have been using, often the lesion gets picked up on CT abdomen or CT urogram done for investigation of hematuria or some other reason, surgical cause, or non-contrast CT done for stone. So for characterization, we just request a triple phase CT scan for just for characterization of the renal lesion, and this is our main imaging modality. And again, for smaller renal masses, clearly at times, if things are not as clear, then MRI scan is usually the second line that we use to further clarify. I was seeing contrast enhanced. It looks really promising, and we do have that imaging available as well, but it is not so commonly utilized as the feeling I'm getting after obviously listening to this talk, as it should be, looking at such good outcomes and clarification with that. So usually, except for very rare cases, if things are still unclear after CT and MRI, then if the patient is, if you're planning on doing any further treatment, then simply a biopsy is considered. And clearly, the modern new imaging, which are under investigation, which I think you will be touching on later on the talk, that is something which we are exploring as well. A couple of clinical trials going on down in London, but certainly I can comment after you have finished, obviously speaking about that, as you mentioned at the beginning of the talk here.
Mazhar would like to add something at this point.
Thank you, Professor. As you have already alluded, and Zishan has also mentioned, all those imaging modalities are still emerging and not as a standard of care. I echo what Zishan and yourself has said regarding contrast enhanced ultrasound. It is promising, but it's not readily available. So, still, standard of care would be the simple contrast enhanced triple phase CT modality. And if the role of MR, as mentioned earlier, there are selective roles. So, these all we are living in challenging and good times that we are focused more about other renal cancer and bladder cancer, just not prostate cancer. Thank you.
Thanks. So, as is pointed out, I think it's clear that the diagnosis and understanding the malignant potential of these tumors is sometimes not that straightforward, coming from our conventional imaging modalities like CT and MR. And as mentioned, even in the first world, the availability of contrast-enhanced ultrasound is an issue, particularly, and also it is the widespread availability probably is another issue. So what else do we have? And this is coming from the recent EAU and the ASCO GU meeting, where there was talk about this molecular imaging. And so obviously for molecular imaging, you need a molecule. And since after the identification of the VHL gene, we know that the carbonic anhydrase 9 is the molecule. Once we have understood how the mutation of the VHL gene results in HIF1 alpha autoregulation control mechanism. And based upon this understanding, we all know that all the systemic treatment for renal cell carcinoma have developed. So obviously there is abundance of CA9 in renal cell carcinomas. So for molecular imaging, we have identified a target, which is CA9. Now, in order to target that, you need to have an antibody. So that sticks to carbonic anhydrase. And that antibody is the girentuximab. So girentuximab identified many years back, and it was not particularly used in this setup. And Mr. Zishan Aslam will allude further to the Zircon trial that he's part of that trial. So you have an antibody, which is girentuximab, and then girentuximab adheres to the carbonic anhydrase 9. And now what you need to do is to tack girentuximab carbonic anhydrase complex with a radioisotope. And the radioisotope is zirconium-89. And this PET scan using this complex has shown significant potential in differentiating benign versus malignant small renal masses. So the study, on which Zishan can say a few more words, has significant sensitivity, and according to the investigators, there is significant inter-reader concordance with all the three readers looking at these scans separately, reporting more or less the same thing. So it has been reported as a pretty straightforward reporting. So it is even for clinicians, probably they will be, once it is more easily available, we will be able to look at the scans and have our own opinion. So significant sensitivity of about 86%. Specificity is also quite high with 87%. So this gives you a very good positive predictive value, although negative predictive value is on the lower side, and an overall accuracy of 86%. So all this is a very exciting data results. And however, the cost-related issue, its easier availability, probably time will tell. So this is the conclusions that I have taken from Peter Mulder's talk in the EAU Paris meeting. And so 89 zirconium girentuximab PET scan is an exciting new development, which is able to identify the clear cell renal cell carcinoma, which is the most aggressive type of renal cell cancer. And it has shown significant potential in differentiating benign from malignant diseases. So I'll stop here and let Mr. Zishan to say something about this Zircon trial and what has been his experience.
Yeah, thank you very much, sir. Just a disclaimer or a clarification that this trial was, which was basically European and American centers and a couple of Australian centers. I was not part of the actual trial, but was on the International Advisory Board to give an independent opinion on the phase 3 results, especially the board included people from outside the trial just to have a neutral opinion. So as Professor Hammad has already explained, the basis of this study related to carbonic and CA9 inhibition and the zircon labeled girentuximab and how it functions. So the results clearly, one of the things was that it was differentiating oncocytomas from benign lesions from the clear cell RCC. The results have been quite promising. The patients well over 300 who had undergone surgical treatments after that. So we had the full sample available to analyze, which is obviously more informative than the biopsy. And very good sensitivity and specificity and positive predictive value between 85 to 90%. There was some debate about a negative predictive value because that was about, I think, 75%, but I'm not entirely sure whether just on the basis of that, the overall results could be underestimated. The issue with that in its clinical implication would be its cost, which at the moment is about 4,000 pounds, but the company thinks that cost will go back. So even if we just put aside the cost issue at the moment and just talk about the clinical application, so our discussions as it evolved is that, or something which I strongly felt and input as well, that it would be a good adjunct to the overall investigative pathway, that is patients' biopsies, especially in conjunction with that. Just on the basis of that, again, probably we might end up in the same dilemma in certain group of patients, where if let's say if the result is more suggestive of benign pathology and we don't have biopsy to back it up, then we would again be potentially in the same dilemma about, okay, what to do? Shall we surgically remove it or not? However, there are a group of patients where we really get caught up in a very difficult situation, like patients who have a single kidney with a mass which is more endophytic, where surgical treatment or could really harm the kidney function, or even bilateral kidneys with a totally endophytic mass, which looks not like RCC and the biopsy is negative. Then again, if this imaging is negative as well, then combined together, I think our overall reassurance or sensitivity might actually just really go further up. And so this is the kind of a group we are looking at. Similarly, in patients who are really young and not keen on having any treatment immediately, that again would be a group where the initial thought would be that this would help with the management, but the decision to discharge the patient and not follow up would again make the situation a lot more challenging. So I think it shows a really promising result and could solve a lot of problems in particular group of patients. And even if cost goes down, I don't really feel that this would be kind of implemented as a routine practice unless it is in conjunction with other imaging modalities, another investigative modalities.
Yeah, I think the conventional imaging of CT and MR would continue to be the mainstay of imaging. The contrast enhanced ultrasound and the zirconium, girentuximab scans, PET scans are going to be a second line or salvage option, particularly where the definite modality, which is biopsy, is difficult, not doable, or not desirable, or it can cause problems, particularly, as you said, in an endophytic mass in a single kidney is a situation where you probably would like to be certain with non-invasive modalities before you would do even a biopsy rather than intervention with a partial nephrectomy. So I think it's important that we have these modalities as a backup in these complex situations where answer to these questions are not very clear. Okay, so on this promising note that we have something to rely to in difficult situations, we have neoimaging. We move on to the second part of this presentation, which is on bladder tumors. Life had been very simple, Mazhar, compared to kidney cancers. You have hematuria, which is either microscopic or gross. You do an ultrasound and it shows that you have a lesion in the bladder. You put a scope inside, do a TUR, and stage the disease. And there you are. I mean, not much controversy, right? Okay. So obviously, complete resection is important. We know that there are significant drawbacks or shortcomings of TUR as well. Accurate staging with resection and sample of detrusor muscle are some of the criteria on which you assess the quality of your TUR. Now, this has been recently challenged by the emergence after the success of PI-RAD to Vi-RAD, which is the vesicle imaging. Because we know that TUR-BT itself is not a perfect tool. It is very much dependent upon the operator. And we always say that don't let TUR-BT as a registrar's procedure and working on a registrar's list rather than you going in yourself if you have a special interest in bladder cancer. So I would personally would like to be involved right from the beginning in the diagnosis of bladder tumors. And one of the most important first step is your TUR. Mazhar, would you agree?
Prof, I can't agree more than what you have alluded and emphasized. The primary TURBT is the hallmark in the optimal treatment of bladder cancer. So as you have said, like, it will going to give maximum information without compromising the quality of tissue sample that you have resected. You can assess the patient under examination and anesthesia, and there are role of radiological aspects, but underperformed TRBT, I think in this era with so much facilities available for training, I think we should be very careful about it. Thank you.
Thanks. So, I mean, TURBT itself has limitations. It has got low sensitivity. It can leave residual disease. Obviously, you will not be able to stage T3 cancers on TUR and ultrasound alone. There is a lack of accurate mapping. We don't know which is the most aggressive tumors, and there are multiple tumors which is to be removed. And there is definitely significant recurrence rate following a TUR. So arm block resection, as is demonstrated in this running video, you can see is one way of ensuring that your TURBT is complete, but obviously it's not possible for every bladder tumor that you see, particularly if you have multiple tumors in the bladder. Our own results, something which was presented in the World Congress of Endourology a few years back, showed that we had almost 96% presence of muscle in an arm block sample compared to the conventional piecemeal resection sample. Vi-RAD. Now, Vi-RAD is something, and I'll take input from Azhar again on this issue, is the new way to image your, and it has found its space in the 23 and now 24 EAU guidelines as well. So these are the various categories of Vi-RAD, and you can see that if you have a stalk and your margins are very clearly defined without any breach and infiltration, this is Vi-RAD 1. If it is less than 1 centimeter, if it is more than 1 centimeters with thickened inner layer, then obviously it's Vi-RAD 2. If there is disruption of the muscularis layer, Vi-RAD 3, although there is very minimal disruption in Vi-RAD 3 of the muscle layer. However, in Vi-RAD 4, as you can see, the SI line is significantly thinned out in this Vi-RAD 4, and in Vi-RAD 5, it is clearly extravesical. So doing Vi-RAD imaging is probably one way of knowing beforehand where you are before you do any kind of intervention. So Mazhar, is it a standard practice now in UK and in your center that MR be done before every TUR?
Professor, since we have been using in breast and prostate, it's an emerging tool, but I think I'm a bit, as urologists, we are very welcoming in technologies and whatever is happening on the horizon. For the bladder cancer, having a pre-resection MR, the bladder needs to be full. So I think if you want to look at the modality, patient who has hematuria, LUTS, and asking them to hold and have their bladder full to have an optimal assessment, I think I will be very careful. It is emerging, but I don't think so it will be the standard of care as per the primary modality for the diagnosis of bladder cancer. I think we need to wait a bit longer, but I have a bit concern. Thank you, Prof.
So when you were not there in the EAU Paris meeting, there was a very provocative talk by Penny Bianco. You know that she is in the international consortium, and the scientific committee was not very kind to her, and they given her a task to talk no TURBT before and do just a Vi-RAD scanning, which obviously didn't sell very well to the urological community. But she came up with some interesting data, and for the NMI urothelial cancer pathway, she said that if you have a Vi-RAD 1 and 2, you do TURBT for diagnostic purposes or therapeutic purposes. If it is low risk or intermediate risk, you probably would treat them as the guidelines indicate. But if you have a high risk cancer, on high grade cancer on your TUR, you don't need to go in and do another TUR as is recommended from 2 to 6 weeks in the guidelines at the moment. and you've done your Vi-RADS scanning and it is 1 and 2, you probably don't need to go and so if your ultrasound is basically indicating a situation where you have a significant size tumor and you think that it does look bad, and you do your MR scan and it came out to be Vi-RADS 1 and 2, and you do your resection and you find that it's a high-grade non-muscle invasive urothelial cancer, you probably don't need to re-TUR as is suggested by Dr. Penny Bianco. But again, it's controversial. If you have Vi-RADS 3 and 4, sampling TUR for confirmation staging is indicated. If you have Vi-RADS 5, you probably just need to confirm biopsy that it is urothelial cancer. You don't need to take any deep biopsy. You don't need to have a muscle in your specimen because you already know that this is an extravesical disease. And you probably would go ahead and plan a cystectomy or whatever you decide as a definitive modality of treatment for your patient. Any comments?
Again, Prof, it's an emerging technology. I think it will be a good avenue to have a head-to-head comparative study comparing these parameters that on the basis of these parameters that have been mentioned earlier. That I think we need a bit more mature data before concluding as a standard of care for this type of pathology, because we know if you have understage high-grade non-muscle invasive bladder cancer which is suboptimally treated, the disease progression is significant. So on the basis of only MR, I will be very careful based on the evidence we have.
We know that TURBT is extremely important, and it has extended TURBT shows to improve survival in all those series in which the patient is either going for trimodality treatment. In this situation, complete TUR is considered. So obviously TUR is not going away anytime sooner. Patients who have neoadjuvant chemotherapy would definitely be better off having a good quality TUR, and obviously, as I've said, for trimodality treatment. The cons for TUR, again, significant delay in definitive treatment. So you're based upon your healthcare system, if it is taking time, we know that ideally between 6 weeks and preferably within 3 months, they should be treated. So if your TUR, the pathology wait, the MR wait, and everything is going to take it beyond 3 months, you probably would miss out on treating these patients on time. There is enough data, and because of the paucity of time, not going to go into the details, but release of circulating tumor cells in the bloodstream. And some of our patients often say that if agar aapne tumor ko chhed diya, to wo to phail jayega. So there is good quality evidence available that tumor ko chhedne se phailta hai, right? Pardon my Urdu at this time. But and as we all know that staging errors is an issue with TUR. So I'll just skip through. I'm not going to the detail. CT again has its pros and cons, particularly the comfort that surgeons have with CT scan, their ability to read CT and have their own interpretation, the short acquisition time, the high spatial resolution of CT scan, and the speed with which it can be done is something. And with our healthcare system coming under greater pressure, it is definitely a modality. So the guidelines at the moment that among the diagnostic workup, one must consider doing a CT. There've been talk about using MR before TURBT. Again, the strength and rating, as is also pointed out, and the logistic difficulties that Mr. Mazhar has pointed out is an issue even in the first world. So although it is in the guideline, but again, the strength and rating is low. So I'll stop here, and thank you very much to both of our moderators for their very, very valuable comment. This presentation and all the other 35 CBU webinars that we have are available on the PAUS Karachi chapter website for all of you to go and see it at your convenience anytime without any registration or fee. I'll see there a couple of questions, and Zishan has actually addressed most of the question. So there is one question by Imran Maiman. Any role of Vi-RADS in high-grade T1 on TUR biopsy? So what you are saying is that once you have done the TUR, after which you want to do, and the patient comes out to be high-grade, non-muscle invasive, you do a MR. So, Mazhar, what is the ideal time for doing an MR scan? Obviously, we have to be very careful about the artifacts after a TUR.
So, Professor, as you have already mentioned, it's an excellent question by Imran regarding the timing for doing MR. Definitely, based on the evidence we have regarding primary resection and for the prostate, doing anything earlier than 6 to 8 weeks will not going to have a positive impact regarding staging. Some people even deferred a bit longer to 3 to 4 months. So we need to be careful what modality we are using and the time. So I think definitely 6 to 8 weeks will be the time that you want to wait. So if I'm waiting for an imaging modality, minimizing the artifact, will it not be better to go in and have a relook? So that's why MR, we need to be careful what we want to achieve.
Yeah, I mean, in the current guidelines and pathway, if you have a high grade, you probably would be going 2 to 6 weeks in and taking another biopsy, making sure that you're not treating a muscle invasive bladder cancer as a non-muscle invasive, wasting time with the BCG and all that stuff. And you probably sometimes lose the boat. And we know that there is significant upstaging on radical cystectomy when we were thinking that this patient really has T1 cancer, and he's found out to have T2. Bladder mapping is another something that is considered as one of the advantages of doing an MR, and you know which is the bad cancer and where to take your muscle. Because if you have multiple tumors, and if you have selected the wrong tumor to do your deep biopsies, and you find out there is no muscle invasion, but actually the muscle invasion was in some other tumor, that would really make a huge difference in your ability to treat this patient successfully. Okay, we are just crossed time. If there are any final comments from Zishan and Mazhar, otherwise we will call it a evening.
No, so thank you very much for such a wonderful talk. I think that has covered everything. The only one comment I'll just say is that there is also an evolving role of system-heavy in nuclear medicine scan, which we have discussed in the past, which is a lot more cost effective. So that is just to be kept in mind after a few clinical trials, which would be really helpful.
Thank you very much, Professor, for the opportunity. And I echo what Zishan and yourself have mentioned. Our approach should be patient-centered and based on the evidence we have. So that should be the way forward. Thank you.
Right. Thank you very much, gentlemen, and all the delegates in our 36th webinar, Conceptual Basis of Urology course. And as I've said earlier, all these are easily available for you to see at your convenience. This one will be available in about a week, 10 days time. All the rest are there for you to see at any point in time. So thank you very much. Have a very good evening, and see you next time, last Saturday of May. God bless.